with quads are not that strong yet. So that helps. Also for the affected upper extremity, you can see the PT standing and holding the limb into extension, right? But if I got the limb externally rotated, okay, with some weight bearing on that limb, means that they're only looking at the elbow at this time, and here the elbow is straight. So standing here also, I am applying good stretch on the long flexures of the hand and the fingers. The shoulder is flexed between 45 to 70 degrees, so which is kind of also putting the shoulder in a stable position. Excuse me. Right? If your patient really needs help, yeah, I will be on the affected side supporting the elbow there. Okay? But the basic or the basic idea of having them standing like this is the patient safety. When they are standing here, they are really safe. Patient is safe, holding on something, they have no issues here. So in this position, what are the interventions that you could apply? You remember the interventions for stability, interventions for controlled mobility. Okay, back to what we have learned last time. Okay, so standing with normal base of support, we start that, and we can apply rhythmic initiation or rhythmic stabilization. Which one? Stabilization. You can apply alternative isometric or stabilization reversals for stability, correct? And you can apply dynamic reversals for controlled mobility when they start doing the weight shift. Okay? Let's do that.
Could you name the ones after rhythmic stabilization and alternating isometrics? You said one more.
Rhythmic stabilization.
And alternating isometrics.
Dynamic reversals.
That's for controlled mobility.
Yes. Okay. Yes, I'm gonna do that now. Okay. Need volunteer.
All American.
Standing here, please. Good. Okay. So, okay, if you take it apart a little bit and move back. Okay. So now, when we first start this, you just need, sometimes you may need a wider base of support. Okay. So we start with the base of support like more than normal. Okay. And then have my patient feet, if he's left side, I make sure that the feet are facing forward and they are parallel to each other. Okay. The trunk should be a little bit forward. Okay. Have his hands on the table. The affected arms gonna be externally rotated. Okay. Should have a gate belt on him. A patient at this level, of course, he would have good trunk control, right? Supposedly, yes. And here he is externally rotated at this hand. Make sure that the elbow is straight and a little bit of weight on that side to maintain that stretch, to maintain the elbow extension. That requires a little bit of weight shift on the affected side. Okay? Don't worry much about the quads here because he is leaning forward at the trunk, okay? And at this case, he is getting mechanical locking for the knee, right? I can apply rhythmic stabilization. So, Jack, please hold yourself, don't let me move you. So here, and you cannot do this. They may fall. Okay, so with rhythmic stabilization, I'm gonna do it again. Okay, this is shoulder against pelvis. No movement should be observed when you let go. Okay, so again, gonna apply that rhythmic stabilization, shoulder against pelvis, shoulder against pelvis, shoulder against pelvis, right? Alternative isometrics or stabilization reversals, okay? So don't let me move you, please. Hold your body straight here. Okay, he's pushing me backward, but you can see no movement, right? Because it's all isometrics. Okay, forward. Same thing. I can apply that to the hip. So don't let me move you forward. Forward and backward. Now forward. Here. I can do that side to side. So I'm on that side and pushing my patient to this side. Hold, please. Okay. Do that at this other side. Alternative isometrics or stabilization reversal. Okay. So we did that on a slightly wider base of support. I can have him with a normal base of support or a narrow base of support and do the same things again, right? So let's have a normal base of support. And now I'm gonna start doing some other stuff like dynamic reversals, okay? So I'm gonna ask my patient to push my hand here and allow the movement, go, and apply resistance from the beginning to the end, dynamic reversals. Then to the other side. Here, dynamic reversals. I'm giving him resistance, but I allow the movement to the end of the range, okay? To the other side. All right? I can have my patient later on, okay, as I do the dynamic weight shift, and with dynamic weight shift, you apply resistance. Okay, you can do at the beginning rhythmic initiation here. So, especially for patients with proprioception impairments, I can do that for them passively first. Okay, shift to the left, I can do that passively first. Okay, and then active assisted. So you start the weight shift, please, and he stops here. I'm gonna continue for him. That's the active assisted component. Okay, and then I would resist. So this is the resisted component of the rhythmic initiation. And then the patient can do that freely, side to side, okay? With you just given, at the beginning, you may be giving him tactile stimuli too, but later on at the second stage of motor learning, okay, it's basically verbal, okay? And you ask your patient to be reliant on their proprioceptions, okay? So practice this many times, right? Okay? So rhythmic initiation can be done. Rhythmic stabilization, alternative isometric, stabilization reversals, dynamic reversals could be applied, and in all directions. Once I see my patient is progressing and doing good job, okay, I would start having the affected side backward, the less affected side forward a little bit. So staggering standing. Okay. It can be also applied as half tandem first. Right? And you apply the same stuff again. So changing the base of support. Right? And then, okay, you would start moving the affected leg backward. Okay? Move it. Okay? And the less affected side forward. So we start with the affected side forward, and then we switch. Okay? So same things could be applied in this position again. Okay? Once I got my patients kind of like okay with those, okay, you can start having less support for him, like you are sitting in front of your patients, okay, having their hands on your shoulder. Okay, remember, you are not stable as the table, right? Okay, and in this situation, I'm gonna start with wide base of support, then decrease the base of support, then move to tandem, half tandem, then tandem spin. Okay, you can do the same things again. All of them could be applied again. Rhythmic initiation, rhythmic stabilization, dynamic reversals, stabilization reversals. All of them could be done. Okay? Any questions here? No? We're good? So let's practice this.